So those of you that are on your computer, I do have my video on. I'm Joan Fernandez, and I'm a Patient Safety Improvement Lead here at the Canadian Patient Safety Institute. And working with me behind the scenes is Natalie Paquette. And any technical issues in that, Natalie is going to help troubleshoot. But I think this is going to be fun. We've got an hour together, and we're going to learn about our award winners for our PSEP-Canada Innovation in Patient Safety Education Award. So in turn, we have a few technical instructions, so questions, and just as Nat was talking about for those that were on, please use the chat box. We're going to mute all your lines just because of the numbers, and so if you have questions or comments, feel free to add them in as we go, or at the end when we allow for time, you can put them in there, but that way we can keep the presentation going, and then we've got, we can address any comments or questions you have when the presenters are done. This webinar is being recorded, and if you do have any concerns, just to dial *0 at any time during the webinar for assistance. So Nat, anything else? We're ready to go?
No, yeah, absolutely.
Okay. So, welcoming remarks. Welcome, everybody. So glad you could join us here for our 2017 Innovations in Patient Safety Education Awards winners. We've got two great speakers up. Our presenters are Dr. Irene McGee, who's an anesthesiologist out of Sunnybrook Health Sciences Centre in Toronto, and we've got Ivanette Hargreaves, who is Manager of Special Projects and Strategies for the Regional Paramedic Program of Eastern Ontario. And they're going to present on how they've used the PSEP program to help them implement patient safety projects within their organization. Specifically, Ivanette is going to talk about the power of a system and how you can use the curriculum and the materials to affect change at a system level. And Irene will talk about the power of one and how one person who has taken the PSEP program, used our curriculum, can go back to an organization and affect change. So I want to tell you a little bit about Ivanette because she's going to be starting. And Ivanette is a registered respiratory therapist and an anesthetist assistant, and and she is a manager at the Regional Paramedic Program for Eastern Ontario. She has a Bachelor of Health Science, and she draws on over 10 years of experience working within the paramedicine field and also working within continuous quality improvement, patient safety principles, and managing and facilitating cultural shift and improvement in patient care. Ivanette describes herself as a perpetual beta. I have set myself on perpetual beta, and I am driven by perseverance, curiosity, and a shameless idealist perspective that almost anything can be accomplished. And this is so true. She was wonderful in working with us at CPSI to bring a PSEP-Canada program to paramedicine in Ontario. And without further ado, Ivanette, I'm going to pass you the ball so that you can begin your presentation. Okay. Oh, and you've already got the ball, Ivanette, so you should be good to go.
Okay, let me just double check here.
Thanks, Nat.
Okay, yes, I have the ball. Thank you, Nat, and thanks, Joan, for that really great introduction. So hi, everyone. Thanks for joining in today. As Joan mentioned, my name is Ivanette Hargreaves, coming to you from somewhat sunny but cold Ottawa, and I want to thank you all for joining in to hear about the work that we did for introducing the PSEP program into paramedicine here in Ontario. So I figured what I would do is to start off with an introduction about what exactly a base hospital is and how it operates, because it's a little bit different than what many mainline or healthcare professionals are accustomed to. So in Ontario, paramedics are actually currently not listed as registered health professionals. and care is actually provided by paramedics under the delegation of appointed medical directors working for what's called a base hospital. In 2008, the Government of Ontario redefined the boundaries of medical oversight, and currently there are 8 organizations such as the one that I work for, and there were previously about 23 of those smaller regional base hospitals. What a base hospital does is essentially provide medical direction, leadership, and advice in the provision of emergency health care within a broad-based, multidisciplinary community emergency health service. Our mandate is to deliver certification, so entry to practice certification, continuing education, quality assurance, and medical guidance to first responders in an effort to consistently improve on patient care provided. Now, our base hospital, which is called the Regional Paramedic Program for Eastern Ontario, is actually part of the Ottawa Hospital. Currently, we provide medical oversight to 9 paramedic services, and the 9 paramedic services actually cover a geographical area of over 40,000 kilometers. So it shows you a little map on the screen there. So everything that's highlighted, which is basically from the border of Quebec down to Prince Edward County and Hastings County, all the way to the border of Algonquin Park. There are 9 paramedic services under which paramedics work under the license of our medical director. You'll forgive me, I have notes. So in the last 5 years or so, our organization has made attempts to introduce patient safety education to those paramedics that are working in our region. We have several staff members now who are PSEP Master Facilitators, and we've taught an abridged version of the curriculum to all paramedics that are working in our region. We've done that as part of our semi-annual continuing education program. We've also presented to the Ottawa Hospital in an effort, to their quality committee, in an effort to extend the reach of the program that we work with. And we've also held a seat on the corporate Ottawa Hospital Patient Safety Committee since 2014. In 2015, a regional workshop was hosted, and it was very well attended by paramedic providers and some of our base hospital colleagues regarding a collaborative culture of patient safety. The workshop was provided by a fellow from SG Collaborative Solutions, which is a company that I think is based in the United States, and essentially presented the benefits of introducing and abiding by a just culture within paramedicine, and has been undertaken by several of our stakeholder services. So, in regards to PSEP-Canada, the PSEP program, what exactly did we do? How did we manage to, actually end up here on a webinar talking about an award that we won? Well, in 2015, the Regional Paramedic Program, or the RPPEO, we identified a strategic goal, a strategic planning goal of introducing PSEP to paramedicine, into the curriculum of pre-hospital medicine in Ontario. The goal of our organization was to influence a system-level change. We wanted to introduce elements such as concepts of just culture, as mentioned earlier, beginning to understand what patient safety means and what it looks like in pre-hospital care, and the importance of reporting of adverse events for the improvement of patient care. Over several months, planning discussions were held with the CPSI staff, both Joan and Natalie, and this was done to ensure that the PSEP-Canada framework was fully utilized. And one of the key components that we talked about quite frequently was that the delivery was done by master facilitators who had expertise in pre-hospital care or in paramedicine. So over the course of the year, the RPPO worked with the CPSI staff and their master facilitators to modify the PSEP workshop for paramedic attendance. We were expertly assisted by the CPSI staff. I cannot give enough credit to both Joan and to Natalie in helping us guide us through this. And the curriculum was modified to include case studies that were relevant to those that were working in emergency services based on actual patient presentation. The aim of the workshop was to propagate patient safety education expertise with key decision makers and support staff working in pre-hospital care. And one of the things that we felt was incredibly important was that we did so with master facilitators who had actual experience in the field that the paramedic participants could identify with and gain a firsthand understanding of how the folks that were standing at the front of the classroom could both identify with their day-to-day working job as well as to overlay that with principles of patient safety education. So, what were our successes? As stated just a short while ago, this took approximately a year. I would say at a minimum of 8 months. And what you see on the screen there really is, while it looks really messy, was a really fairly good interpretation of how it was that we were able to gain success. This truly was a multidisciplinary, multi-organizational collaboration. The expectation that we had in crafting the workshop was that there would be regional influence. What occurred as a result of the excellent collaboration that happened was uptake of the PSEP-Canada program for pre-hospital medicine on a far grander scale than what we were anticipating. In the end, the participant list included representation from the Ontario Ministry of Health and Long-Term Care, specifically the branch that we report to, which is the Emergency Health Services branch. We had participants from Accreditation Canada. We had 6 emergency management services. We had six paramedic services that sent staff. We had 2 of our partner-based hospital programs like ours, and we had 1 preparatory college that actually sent several staff to see what it was that we were trying to implement and to see what it was they could learn from the PSEP program. The collective reaction to this initiative has been strongly supportive and diverse enough within the pre-hospital system in place in Ontario to have the curriculum gain some spread across the province. So while we started thinking that we would like to bring this into our region for our regional partners, we've actually now been having conversations about PSEP across the province in many, many different ways. One of the key successes to this initiative was speaking about the workshop at every possible opportunity. In doing so, there was discussion regarding PSEP Canada for pre-hospital care at several regional, provincial, and national forums in which emergency service providers interact and form decisions. The result was a rich participant list, which included representation from many aspects of our system, as mentioned earlier, including paramedic educators, frontline and administrative staff, and government staff members. Now, one thing that we didn't anticipate was the reach that came from partnering with CPSI. We actually had 2 people in the room that joined us from United Arab Emirates, which our network obviously doesn't extend there. So it really was an incredible collaborative participation. Now, within Ontario alone, the communication strategy included approximately 15,000 contacts. Those were people working in 53 paramedic services, 8 medical oversight-based hospitals, numerous educational institutions, and countless working groups. The challenge also presented an excellent opportunity for the infiltration of information about the workshop to occur at system level. So I really feel that by sort of coming at this and trying to advertise it in as many venues and as many arenas as possible, that we really were able to start to influence discussions at many aspects of the actual industry of pre-hospital medicine. So by utilizing contacts that both the RPPO and CPSI had, the message really spread effectively throughout Ontario and had reach across Canada. One of the things that we tried to do, that we did, was to use the same marketing materials and messaging that was created by CPSI so that there was no confusion regarding the participants and the partnership that we had with CPSI. There was some overlap with messaging, seeing that some of the key influencers in the industry heard about the workshop from different avenues. So having the workshop advertised and spoken about at every possible event and meeting had the impact of amplifying the importance of the reach. As I said earlier, we tried for a local reach, and we actually had some impact because we had people hearing about it at national events. So while the patient safety momentum here within paramedicine has been propelled by our leadership and our paramedic staff, the uptake has actually been a bit slower with our physicians. One of the ways that we found was actually really quite effective to gain their attention was in obtaining continuing education credits. It was actually instrumental in highlighting the value to our physician medical directors of the PSEP-Canada content that we were able to modify. So we actually had our medical directors in the room with us, and they came away with a new appreciation of what we were trying to do because they had that hands-on experience and they were able to actually experience it with the paramedic participants that were in the room. So what's next? Truthfully, Joan and I have had this conversation a couple of times, and I really truly feel that the work has just begun in regards to patient safety in paramedicine. All of the work that has been done in preparing for the PSEP education rollout that we did last year really has provided a solid basis for implementing education and fostering interagency discussions about concepts such as just culture, the importance of trust, the importance of reporting of adverse events, as well as dynamic collaboration in creating a safer environment for both paramedic care providers and patients alike. So working with CPSI to modify the PSEP curriculum for pre-hospital care really truly was a natural progression of the work that we had already begun. As this was the first of its kind in pre-hospital medicine in Ontario, the indicators of success were fairly broad. There was a desire to influence our colleagues and decision makers to gain an understanding of what patient safety means in pre-hospital care, and in many ways define what patient safety means in pre-hospital care, as well as to adopt the principles widely known for patient safety education. Incrementally, and in alignment with our ongoing continuous medical education, we have begun to implement patient safety principles into our ongoing paramedic curriculum. So one of our eventual goals would be that patient safety discussions become the norm within paramedicine, and it's not something that is layered onto medical education or continuing medical education. And certainly we would really love to see a day when patient safety education is the norm in preparatory education, as well as ongoing continuing education and day-to-day working competency. Okay, Joan, I'm going to hand it over to you to see if there are any questions on the, based on that. And if not, I will gladly hand over to Irene.
Okay, thank you, Ivanette. I just want again to let people know that if you do have a question or a comment for Ivanette, to please put it in our chat box, and we will address it. So, just reiterating what you said, it was a real close collaboration in terms of working to make sure that the curriculum fit, the needs of the participants. The other plus was that we have several of our master facilitators within our PSEP-Canada program who, like you said, had the background in paramedicine to be able to come in and really, talk as peers and know exactly their reality in terms of dealing with pre-hospital medicine. So, yeah, it was a pleasure. A lot of work, but definitely worth it. Oh. Okay, so there's nothing in the chat box at this point in time, and I think if you're okay, and Irene, if you're ready, I'll pass it over to you because I know that Irene has a lot to say. All good too. So Nat, I've got the ball now. Do you want to pass it to Irene, or will I just move the slides?
No, go ahead and do your introduction, and I can do the passing behind the scenes, Joan.
Okay, perfect. Okay, so now we're going to hear from Dr. Irene McGee, who is a anesthesiologist, as I said, from Sunnybrook Health Centre in Toronto. And just a quick bio for Dr. McGee. Since graduating from the University of Toronto in 1984, she has been active as a physician educator at the undergrad and at the postgraduate levels. The importance of non-technical skills in medicine, as recognized in the CanMed's objectives, motivated me to develop a communication and collaboration curriculum in the anesthesiology residency program. Most recently, she contributed to the Aspire initiative and to the CPD curriculum development. And so for those of you on the line, the Aspire program was a joint initiative that CPSI did with the Royal College of Physicians and Surgeons in Canada to develop a program. Foundation was the PSEP-Canada program, and then they developed this program to train residents on patient safety. So the Aspire program has been offered. We're going into our 4th year now of offering it with, again, the foundations in the PSEP program. Currently, Irene's work is focused on forging more robust communication among all members of the healthcare team, including the patient, and such interprofessional collaboration is key to safe, compassionate, and excellent care. So, Irene, if you're ready, the ball is in your court.
Okay, thanks a lot. Can you hear me?
Yes.
Hello there, everyone. Thanks for joining us, and thanks, Joan, for that introduction, and thanks for that awesome presentation, Ivanette. I'm now going to give you a different perspective from inside the hospital. I'm looking for my slides right now.
So there, Irene, just the arrows. You can click to the next slide. They've been embedded.
Okay, great. I see our presenters. And I'm clicking on the, okay, gotcha. Okay, thank you. And back, and forward. Okay, that is, okay, there we go. That does not show very well, so I'll do some reading from my notes as well. It says the Power of One Innovation in Patient Safety Education Award, and my award was for a communication tool that will improve performance on ad hoc teams. This is going to be interesting. All right, so you have to listen to me now that you can't read anything. So I don't know if you realize the average surgery patient is seen by 27 different healthcare providers while in hospital. And connecting effectively with so many healthcare providers is essential for safe care, but obviously difficult because of complexity. Now, does this apply to your world? Patients with multiple care providers, teams of experts that are not always expert teams. It can set up real challenges for communication. Actually, to me, it seems like hot potato meets broken telephone sometimes. I see patients in a pre-op clinic before their surgery, and I'm hearing much too often. Patients are asking me, who is my doctor? They never told me about that. I'm still waiting to hear back. I just had the blood work and x-rays done. Do I need them again? Everyone seems so busy, they don't have time to talk. This really bothered me, and it led me to want to find a way to improve things. I took the Patient Safety Education Training Program with CPSI several years ago, and I've never looked back. The diversity of expertise, interprofessionalism, and patient involvement was remarkable and inspirational. And then I did a year of mentorship and educational research, and this is what I came up with. Okay, iStartN. We've talked about this already. I'm going to move to the next slide. All right, that's better. All right, this is the tool. At first, the iStartN tool was intended for use by anesthesiology residents on teams such as Code Blue and traumas. But then residents told me that they found the tool really helpful in other clinical settings. In teaching centers where residents move from place to place, they are often working with people they barely know, with unfamiliar policies, procedures, and protocols. And they said that ad hoc was actually the new norm in medicine, and the tool gave them agency and helped them be more grounded. So the power of one is about I-START-END, a cognitive aid in the form of an acronym that facilitates team building by an individual in the moment to ensure effective collaboration, accountability, and seamless transfers of care occur for our patients. So let me take you through it now. Identify the leader. This may seem elementary, but it is essential to coordinate care, follow through, and plan beyond the present moment. So you need to introduce yourself to the leader by your specialty and experience level. This will also role model for others arriving to do the same. The leader will be more effective at task delegation when they know the expertise of those around them. Get the story. What happened? How did it happen? And what else is going on? Context is critical. Every patient with a given illness has a unique story. By understanding it, we can care for them better. Tasks need to be coordinated and assigned by the leader. In keeping with closed-loop communication, affirm what you heard, what task is being asked of you, and accomplish it. Or perhaps you may need to adjust it based on your skill, judgment, and experience. Always checking back with the leader and keeping them in the loop. Resources, such things as monitors, equipment, drugs, more help. Anticipate what might be needed next. This is not home turf. It will always take longer than you think to get the things you need. Timely updates. Ad hoc situations are continuously evolving. There are many bright minds on the team. Engage them. Ask, what do you think is going on? This may mean updating the story and so on, and encourages speaking up behavior. Before leaving, it's important to have a formal handoff to ensure seamless transitions of care. Give an exit evaluation to update the leader before leaving. Summarize what you did, and then tell the leader what you think might happen next, and who will do what by when, and leave your name and contact number for follow-up. Document your interventions on the chart and debrief. Is there anything that could be done better next time? This is a laminated credit card size cognitive aid I developed. On the front side, the big I is for identifying the leader and introducing yourself. The symbol in the middle of the I spells out ad hoc, and it is meant to depict the episodic nature of these encounters. It's really like parachuting into a bedside, anywhere, anytime. And the back of the card details the rest. So, what do I mean by ad hoc, and how might this be relevant to you? Well, let's say you're summoned by pager or otherwise to deal with a particular problem. You are basically called ad hoc for this express function. This means the focus is likely task-oriented. Then, others arrive whom you don't know and will likely not work with again. Leadership is not always clear, so everyone sort of does their own thing. No one is on home turf, and it feels uncomfortable. You stay in your silo. Trust, engagement, commitment, accountability, speaking up are not supported in such settings. Ad hoc can set us up to fail. The I-START-END tool can help us do better. It sets the expectation that team members engage in meaningful and timely dialogue. The tool moves the team from performing not only as a group of competent individuals, but also as a collectively competent team. The new norm in medicine is such episodic care encounters, so we need to change the way we relate as a healthcare team. Forging connections with each other will also make our work more meaningful, rewarding, and even joyful. It becomes about being and not just doing, and this is supported in the literature. Next one. Moving on. Okay. 9.5% of all deaths result from unwanted variations endemic in healthcare. Developing consensus protocols that streamline the delivery of medicine and reduce variability can improve quality and lower costs in healthcare. Okay, move on. Oh, good. And then we have the naysayers. Not another tool. Checklists are for dummies. Well, not so, Steve. In many cases, checklists are about getting back to those basics that everyone agrees on and making sure we have them hardwired into our processes so they're not forgotten. It's about making the right thing to do, the simple thing to do. All the key concepts, so what's unique about iStartEnd? Well, it integrates all these well-recognized and established ideas, practices, principles, and processes into a framework that is versatile, easy to remember, transferable to any setting, and easy for any individual to apply. So on this list, it says Crisis Resource Management, Health Quality Ontario, High Reliability Organizations, Lencioni and Team Dysfunction, Systems 1 and 2 by Crosgery, Lingard and Collective Competence, and Complexity Theory. I'm just going to say a few words about each of these. Okay, this is probably familiar to many of you. All the key concepts of CRM, which is more than 10, may be difficult to recall in the moment, so iStartEnd actually uses them and operationalizes them into a simple framework. Health Quality Ontario has set out a document describing transitions of care. To date, the focus has been on information transfers. This document sets out the importance of ensuring that specific managerial and relational issues are also addressed on transfer. Who will do what by when, anticipating and planning for next. No point in reinventing the wheel. NASA, the nuclear power industry, and other high reliability organizations have highly standardized transitions of care. The processes are transferable to what we do and has been incorporated into this tool. A very busy slide from Pat Crosgery's work. It tells us that when we're outside our comfort zone, as in some ad hoc settings, we will operate from a more intuitive base. This is System 1. Which can make us more error-prone. By encouraging dialogue and engagement, asking others for their input, the more analytical System 2 can improve decision-making. And from the business world, Patrick Lencioni has described the 5 dysfunctions of a team. iStartEnd addresses and tries to improve on these. Lorelei Lingard from London Health Sciences Centre has identified that individual competence is not enough in our complex world. Collective competence, being able to connect effectively with each other, is key to silo busting and better coordination and delivery of care. Everyone's view of the world is different. The way we interpret an event is grounded in our past experiences. It is the lens through which we evaluate situations. Note how helpful it is to have more than one perspective. We can be more than the sum of our parts. iStartEnd encourages individuals to start that conversation. I hope you will. Thanks. And on that note, I would welcome any questions and comments from anyone in this audience as very smart people listening. Thanks again, everyone.
Thanks, Irene.
You're welcome. And I should note that I can send you a new pack of slides, so if you want, because it's obviously it was very difficult to read any of those, and that will they can be available for others, or however else you do, you archive them. Yeah,
okay. All right. This is being recorded, and it will be put up on the communities of practice, so it will be made available to participants. While I'm waiting there in the chat box, if anybody wants to add questions, comments, please do. But Irene, from what I'm interested in is when you, like, how did you sell this within Sunnybrook? How did you, because everything that you're talking about in terms of the communication, the piece around the new norm is about ad hoc teams and that. What did you have to go? What process did you go through to get the different teams in your organization, and maybe what are you going through?
Yes, it is an ongoing process. You're absolutely right.
Yeah.
I started with residents because I am part of that teaching program already. So you start with what you have and you can do, and presented it to the University of Toronto Postgraduate Anesthesia Committee. and then did a simulation study with residents that allowed them to do simulations before and after they learned the tool, and then took that evidence and presented it at local, we have Sunnybrook educational days and interprofessional days, and so I started to spread the word that way. People came to me, were more interested, and I've been involving it's really piece by piece that I'm doing it. The engagement is the challenging part. So I presented to the trauma team, to the OR teams. I'm presenting across the board interprofessionally, and actually the next step is that I am working on a tool that mimics or mirrors this in order to help patients engage their healthcare providers with kind of like a similar iStart and framework so that everybody's reading from the same score, essentially, and it's just simplified so that they can actually use it. And so that's the next step in this process, because I kind of want to push-pull phenomenon where we're communicating this way, but we need to make sure the patients are receiving it and are engaged in turn, and that's how I think we'll make a difference. So I'm still working on this, and I'll keep you posted.
Yeah, well, no, certainly, patient safety and that, it's a journey, not a race in terms of, how we go. So you work, in terms of the patients and engaging patients, you work with the family councils that you have or the advisory committees? Yeah.
That's right, and I've just submitted an application to receive assistance with this, and on my team is a patient, myself, a nurse, a pharmacist, and one other person who escapes my mind right now. But so we're going to get some training to try and get this project up and going, and as soon as I hear about that application, I'll send it your way. And Donna Davis actually has been helping me with regards to how she's had so much experience with patient engagement that I just was speaking with her, and she gave me some ideas about how to go about engaging patients, because that's really kind of, it's interesting. It's a form that we really have stepped away from because of the hierarchical nature of medicine, the traditional kind of medicine, which is really going by the boards in a hurry.
Yeah, yeah. I don't know. I know you said that a couple of people from Sunnybrook were on, and I don't know, and I hate to put people on the spot, but I will. If there's anybody from Sunnybrook that's on that you have used this, I would be really interested, and I'm sure our listeners would too, in terms of how you found that process of introducing it and using it, and if you've noticed gains from it. So you can, if you just chatted, because everybody's muted, if you could just chat in there, that'd be great. We appreciate it. And so in terms of using the PSEP curriculum, Irene, it was basically, you took the program, and then just as you got thinking about the different areas of patient safety and what you need to focus on, and looking at your organization, you saw that this was an area, teamwork and communication are clearly, an area that all can always work on, but you felt this was the one that you needed to.
I think that what really hit home was we kept talking about teams, and my experience in providing care in this hospital setting was it wasn't really a team because of the changing players with whom I had to relate on a regular basis. From day to day, it's different. So I kind of felt that we were all itinerant, and I wanted to ground us in some way. Yeah. And in a way, maybe it's like the safe surgery checklist. So at least you know that you're supposed to talk about something, that everybody's supposed to get a turn, everybody knows should know everybody in the room, and then we go from there. So I was thinking, well, wouldn't it be great if we could do this beyond the operating room setting? And the pieces that I learned from the PSEP program, they were huge. What it taught me is, first of all, to do a needs assessment, which I did.
Mute off.
Oops. Are you still there?
Yeah.
Okay, something said in my ear, mute off, so that's good that the mute is off, yeah.
Well, Natalie and I, Natalie just unmuted everybody, so we're going to call on Josh after you're finished.
Great. Yeah, I was just going to say, so the pieces that I used was the needs assessment, and then I used the CRM, which was mentioned in the course, and then I also learned about high reliability organizations, Pat Crossgary's work. So all of this started to launch me in the right direction, I think. And I touched base with other people who are doing quality work, like Josh, who you'll hear from in a moment. And we've actually, he's actually active in the curriculum now. I'm hoping that we can introduce this tool into the curriculum and take it from there.
Yeah.
Hi, everyone. I'm here.
Hi, Josh.
Hi, Josh.
Hi, thank you for including me. So, yeah, I've used this tool successfully, and I think it's excellent. And the components I want to highlight are really, when you walk into these situations, it's chaotic, and it's very important to help get the story and the background, which are often glossed over because there's so much happening. So Irene's tool is very unique, as it really helps establish what has happened up until this point by getting the story and what the active tasks are. The other thing I really enjoyed and I want to highlight, and I still use this every time I encounter a similar situation, is the part before leaving, anticipating what's next. Even when you've stabilized the patient and there's some kind of resolution of the crisis, you really want to anticipate what other things are going to get you and the patient in trouble next. And the tool really helps the team focus and brainstorm quickly and come up with contingency planning. And I think this was a very important thing to include in the ad hoc tool.
So, Josh, is that like the before leaving part when
exactly.
in terms of the, okay, I see, gotcha.
And this is often glossed over, you know, the patient's stable and you transfer him to ICU, okay, but what's next? Who do we need to call? What diagnostics need to be run? What happens if they decompensate again? And what's the contingency planning for that?
I think that's a really good point, Josh, because what happens is the situation keeps evolving. Like, you're really just capturing it at one point in time, and to think that it's over, that you walk away and it's over, it's not over, right? So it's really important to put those pieces into place, and I think the most challenging thing is basically holding people accountable in this setting, because really often their mindset is they've come to do this and they did that, and now they're done. Like, you could consider anesthesiologists as agents of the airway. So if the patient doesn't need an airway intervention, should we just leave? Well, absolutely not, because we have many other skill sets than just the airway, right? So that's one of the things I think that you want to gather at the end and say, okay, what will happen next and who is going to do what? And if we need to call you back, how do we get a hold of you? Because that pager changes hands many times, and you might want actually the person who attended the trauma in the first place, not the one who's now carrying it 2 hours later.
Yeah. You know what is remarkable to me, and I know that this is, I'm going to be plugging our program again, but I guess what it is I'm just going to move our slides along so you have the presenters if you want to email them directly. But it's the fact that what I see, Irene, is that in terms of the PSEP, and I go back to that because that's, you know, the award is a result of you taking the PSEP program, or I'd like to think, but it's the idea that,
no, it's so true, because really I'd never experienced in all my years in medical school and pre-med, I never experienced an environment where all the healthcare professionals, everyone was there, sampling from everywhere, the paramedics, the nurses, the physios, the OTs, the patients, other physicians. So it was so real, and it was so great, because we actually all care about the patients, but we care in different ways. And it was just opened up my horizon in terms of the possibilities. So that was, the environment was so rich, and it was not something that I had experienced before. And in fact, I went to a meeting recently, and I think, I'd hate to say it's about Aspire, and the way they put up one of the questions, it was totally physician-oriented. And it just glared at me, and I said, hang on, we should not say physicians, we should say healthcare professionals, because we want to include everybody. Now, Aspire is an awesome program. It was just a one-off little thing, but it was really evident to me that that did not represent what the whole picture was, only a small piece.
Yeah, and you know, and so for me, it's really it's lovely to hear that you know, when you attend this program, that it just does open up your eyes to, you know, you've got to look at all these factors, and then so you go back to your organization, and you know, just through the power of one, really, you sit down and you think about how can we make it better. So I thank you for that. So I put up on the slides here for those that are on their computers, the contact information. Is there any other questions or comments that people would like to make?
I would love to ask Ivanette when her program is coming to the Central Ontario area, because I think I told you the other day, Ivanette, my son is a paramedic, and I think you could definitely use some of your patient safety coaching and even awareness to start with.
Oh, thank you for that.
I'm actually really quite happy that you asked. Joan and I have been having some conversations about where we're headed next, and I think there is more to come. Joan, maybe I will hand that answer over to you at this point.
Yep. So I've got up on the screen now that we have, at this point in time on the books, there's 2 PSEP sessions that are happening, both in Toronto, one in May and one in September. These are not, these are general, if you will, courses, so anybody can come. The Toronto one tends to be more of a national one, but the one in May, we're partnering with the Ontario Hospital Association. They're one of our affiliate programs, and so they're running the May one. And in September, we partner with the OHA to deliver a national conference. But if anybody is interested in having a, I call them boutique PSEP-Canada session, please feel free to send an email to us with the address there, and we can certainly talk, because it's kind of, you know, how it's worked, certainly with Ivanette, and, you know, we just had the conversation, and we will continue to have the conversation, Ivanette, and let's plan another one.
I love the idea. Happy to help.
Okay. Okay, well, I don't see any other chats, any other questions. Your lines are unmuted if somebody wants to speak up now.
Hi, it's Charissa Microys in Ottawa.
Hi, Charissa.
Nice to hear everyone's voice. I haven't seen some people for so long. And Irene, I love your talk. I mean, I remember when we met in Aspire a few years ago, and great to see what it's come to. I knew back then that you had a great idea, and it's great to see it taking off. I have some ideas about spreading this to other centers, but I thought maybe I'd also ask, did you have any plans on spreading to other centers?
I am ready to go. It's no, I'm happy to spread it. Like patient safety, like it's so near and dear to my heart, and anything I can do that makes a difference to the front lines is what my intention is. And so, yeah, I need the impact happening.
Yeah. Well, I mean, obviously this is a great venue for sharing. And obviously we had already actually just recently connected to talk about the CAS meeting.
Right.
So we will have to chat more about this and see how we can start spreading this idea.
I just want to tell you that I remember meeting you and you sharing your story of the failed airway. It stays with me to this day. And just like patients have stories, healthcare professionals have stories, and it can change us for life. And I think, you know, I do anesthesia by anecdote. You know, one experience changes your life. So thanks very much. And I've enjoyed the course and especially your input into it. It was great.
Thank you.
Thanks, Charissa. Anyone else? Well, I do want to thank you for everybody for joining in. For those of us in Eastern Ontario, over your lunch, in the West for your morning coffee, and in the East for your afternoon tea. And
Joan, I thought I saw Debbie Voskamp come up briefly. I don't know if she had a question or changed her mind, so I just wanted to give her that opportunity, if in fact she did.
Yep. Debbie?
Get on here.
I see Debbie. Debbie, do you have anything? Oh, okay. Nat's just saying it's just feedback.
Okay, no problem.
Okay. Okay. All right then. We're a little bit early, but you know what? We've had 2 powerful presentations, so it's kind of the rapid fire content that you've got. Any questions, please feel free to email us, or the I'll put the emails back here of the 2 participants. Where is it? There we are. Ivanette's and Irene's emails, if you'd like to contact them directly or to contact myself here at CPSI or the PSEP program, and we're always happy to spread the word. So with that, I will say goodbye, and thank you, everyone, for joining us.
Okay, thanks, Joan. Thanks, Natalie, and all.
Thank
you both. Thanks for having us.
Okay.
I'm hanging up now.
Yes, that's great. Okay, thanks. Thank you. Goodbye, everyone.
Bye-bye.
Bye.